A very good afternoon, everyone. It is with great honor and pleasure to welcome you all to this 18th Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis among children. On behalf of the National Institute of TB and Respiratory Diseases, I extend a very warm welcome to our esteemed Deputy Director General TB, Central TB Division, Professor Urvashi B. Singh and her team. I also extend my heartfelt welcome to the directors and representatives from NIRT, NTI, state TB officers, and directors of STDCs, esteemed faculty members from medical colleges, district TB officers, and medical officers across the country. Now, please let me introduce the faculty from NITRD. I am Dr. Dulika Dhingra, Specialist Pediatrics at NITRD. And to my right is Dr. Sangeeta Sharma, Chief in charge of the National Center of Excellence for Pediatric TB and former Director of NITRD. To my extreme right is Dr. Alok Yadav, CMO, NFSG, and pediatrician at NITRD. To formally start this important session, I now have the honor of inviting our respected and visionary director, Dr. Upasana Agarwal, ma'am, to deliver the inaugural address. Over to you, ma'am.
Thank you very much, Dulika, for this very kind introduction. Uh, Highly undeserved. But I congratulate the pediatrics team for having such an important discussion today on congenital TB. There would be many in the audience who would not even know that there is something known as congenital TB. And as Dr. Sangeeta Sharma ma'am was telling me that they, during the course of discussion, they will actually decide whether it is congenital TB or not. And I congratulate the AIMS Rishikesh team from bringing in such a important case. My regards to all the seniors and colleagues in the audience, and my regards to DDG madam. And with these few words, I hand back the mic to the dais.
Thank you, ma'am. I would now request Dr. Sangeeta Sharma, ma'am, to address the gathering and also welcome DDG, ma'am, Professor Urvashi B. Singh. Over to you, ma'am.
Yeah, thanks, Dulika. As we are all aware, we have got a good attendance today, and hope more will be joining in. This pediatric TB session we had to prepone. In fact, the session which was due in October, it was coinciding with our festival of Diwali. So we had to postpone it, and now we are preponing the November session. So, that is the only thing which I would like to address here. Now, coming to pediatric TB, we are all aware, India, the reason behind this eco is that we need to increase our awareness so that we properly manage the children starting from 0 to 18 years under the program. Pediatric TB is a significant chunk, and India again tops the world. Out of 10.8 million, 1.3 million are children, and we have according to WHO, the 12% caseload is in children. And for us, we share one third of this global burden. And without wasting words, I would say that notification under our program is still sticking on to the figure of 6 to 7%, and we have an estimate that we're looking at about 12 to 13%. So we all need to, collaborate with each other and need to pull up our socks and increase our notification, do proper management of pediatric TB. So now we are lucky that DDG ma'am, Dr. Urvashi Singh, has always been kind enough to be present during the session and participate in all the active discussions. So, Dr. Urvashi, I request you for kind words, please. I'm sure you must be there with us.
Good afternoon, Dr. Sangeeta. Thanks for
Yeah.
the kind invite and thanks for the Institute to hold these sessions periodically. And these are very, wonderfully conducted, great learning sessions for all who care to join. So, my due respects to all the seniors, all colleagues who have joined here, and all those who wish to learn are here today. Congenital TB is one area, Dr. Sangeeta. The topic you've chosen is very, very important. And frankly, this is an area where not a lot of people are actually aware of, like Director NITRD, Dr. Upasna, who's always been supporting, and the previous director, Dr. Sangeeta, and the Dr. Manpreet. Everybody was very supportive of the eco clinics and the difficult to treat pediatric as well as adult MDR-TB clinics. The congenital TB per se is a much ignored area, and we have published something in the year 2006-7 where we also did molecular typing from the child and the mother, and we were able to show it was, the neonate got the infection from the mother. It is an often, I may not say with the word ignored, but missed diagnosis. Of course, you will deliberate in detail about it. And I wish you all the best with the discussions. And Rishikesh team, good that you're looking at such less reported cases to make the awareness for the reporting to increase, as Dr. Sangeeta said. Of course, pediatric TB per se is a topic where we need to look at more diagnostic modalities. And at AIIMS Delhi, we have done, several newer diagnostic methods where we've looked for urine, where you looked at stool as non-invasive samples, where either a nucleic acid amplification-based technology could be used or an antigen-based technology could be utilized, especially because in children in the periphery, it becomes difficult to collect gastric aspirates, even induced sputum, lavage, of course, or even bowel samples are difficult to collect. Now our thrust is to find reasonably good samples which are non-invasively collected, and this would soon be available under the program. So over to you, Dr. Sangeeta, for the academic deliberations, and we can discuss further maybe towards the end. Thank you.
Thank you.
Thanks.
Yeah, thank you, Dr. Urvashi, ma'am, for your kind words and your continued support. Over to Dhulika now.
Without any further delay, we would now start today's session. Today's presenting team is Department of Pediatrics, AIIMS Rishikesh, led by Professor Meenu Singh, CEO, AIIMS Rishikesh. The case presenter is Dr. Srijan Sinha, Senior Resident, AIIMS Rishikesh. And the national expert for today's session is Dr. Sangeeta Sharma. Over to team AIIMS Rishikesh.
Hello, good afternoon, one and all. Am I audible?
Yes, you're audible.
Yes, I'll share my screen.
I would just like to ask, is Dr. Meenu Singh also logged in?
Yes, Sangeeta, I'm online.
So, actually, it's not me.
Huh? Can you hear me?
Yeah. Thanks
Okay,
for coming
all
back
right.
to I was saying that for today's session, as you logged in, we have an actual expert, and we'll conduct a session together. Thanks for joining in with all your busy schedule. Thank you, sir. So over to the team.
Are the slides visible now?
Yes, please. Yes.
Good afternoon, one and all. Today we have gathered here for the monthly pediatric TB echo meet. I'm Dr. Srijan Sinha, Senior Resident in the Department of Pediatrics, pursuing DM in Pediatric Pulmonology and Intensive Care at AIIMS Rishikesh. My mentors for this case were Dr. Vyas Rathore, Assistant Professor, and Dr. Meenu Singh ma'am, Director of AIIMS Rishikesh. So starting off with the case. So I'll be discussing a short case of tuberculosis, which was an interesting case because the antenatal and natal history were quite unclear, but the further history and management were done at a peripheral center. And when he came to us, he was around 4 months of age. So we had a doubt on whether this was congenital TB or a postnatally acquired tuberculosis. So concomitantly after the case, we will have a short discussion on congenital TB, how to suspect it, and how should we rule it out and how we can manage it. Starting off with the case, the master A 4-month-old male infant, parents belonging to district Rudraprayag of Uttarakhand, came to us at 4 months of age with the complaints of abdominal distension, which had started at around 1 month of age, which was progressive in nature and hard to touch. Along with that, the second chief complaint of the parents was that the child was having poor weight gain. The child was born at 8 months of pregnancy. The birth weight was around 1.9 kg, but when he had come to us at 4 months, the weight was around 3.8 kgs. The child presented to us with abdominal distension, which was gradually progressive, and poor weight gain. 3 kg weight was documented at 1 month, and the weight at when he came to us was around 4.1 kilograms. There was no history of fever, no history of jaundice, no history of any loose stools, no history of any cyanosis or suck cycle. There was no history of respiratory distress or cough as well. No history of any rashes, bleeding manifestation, or decreased or any increase in urine output. The abdominal distension was gradually progressive, and it was quite marked by the time he came here. The birth history was quite eventful. According to the parents, even after multiple probing, the mother delivered the child in the bathroom. She had not had any antenatal records till the 8th month of pregnancy. And the child was taken to the hospital immediately. That time he required no, the weight was around 1.9 kg, so he was discharged after 1 day. However, the mother developed complications and she had to be rushed back to the hospital on day 3, on which she was diagnosed with query sepsis or query amniotic fluid embolism, and she passed away on the same day. Because there was no antenatal record, there was no history, so we had to probe further and ask whether that the mother had any history of weight loss, any history of poor weight gain, any history of infertility. But this was the first child, and even the mother had even the father did not know the history, and the child was incidentally found along with the mother went to the washroom at the 8th month of pregnancy, and the child was born. That was the history given to us and corroborated by the other family members as well. So when the child came to us, he was being cared for by his grandmother, and he was exclusively formula fed because the mother was not there. The child had been first admitted at the Government Medical College in Srinagar in Uttarakhand at around 2 months of age, and there for this similar complaints of poor weight gain and abdominal distension, initially workup for congenital infections was done as it was an unsupervised pregnancy, and regular fever workup was also done, which was all came out to be negative. However, he was started on anti-tubercular treatment in the month of May 2025 strictly on a clinico-radiologic basis. They had tried to find out the organism using gastric aspirate, but it was documented to be negative. And when he came to us, he was nearing the end of intensive phase. However, he was referred to AIMS Rishikesh as the child was not having adequate weight gain and suspicion of DRTB was there. And more importantly, that the right upper low opacity, which was seen in the previous X-ray, was not resolving, and according to the previous hospital, had increased in size. So first I'll be presenting to you the examination. When the child came to us, he was severely underweight. He even had microcephaly. That led us and the previous treating team also to suspect the diagnosis of torch infections, and the length was less as well. On general examination, pallor was present. However, there was no icterus, no cyanosis, clubbing, any lip peripheral lymph nodes, or any edema. Yes, sir. Sorry, sir, I could not get you. So the Z scores were less than -3, sir. That is why he was classified as chronic malnutrition on acute. The child was 4 months of age. The vitals were stable. It was 112 beats per minute. The respiratory rate was around 48 cycles per minute. Saturation was 96% on room air, and temperature was 97.8 degree Fahrenheit when he came to us, and the child was hemodynamically stable throughout the hospital stay. On respiratory system examination, on inspection, the upper airway, here nose, throat were normal. There was no nasal flaring, no tracheal deviation noted, no retractions or any use of accessory muscles of respiration. The trachea was central and midline on palpation, and bilateral chest expansion was equal in both hemithoraces. And there was no dullness appreciated on percussion. However, on auscultation, the right suprascapular, interscapular areas had bronchial breathing. Other areas had equal bilateral and equal air entry, and there were no other added sounds appreciated on auscultation. There was splenohepatomegaly with distended veins. The spleen was enlarged up till almost the umbilicus. The liver splan was around 9 centimeter, but S1S2 were present with no murmur, and CNS-wise, the child had good cry reflexes, activity and tone. And even on the age of 4 months, the child had started to attain partial neck holding, appropriate as per age, and social smile had appeared. This was the first chest X-ray. done at the local medical college at Srinagar, in which you can see over the period of 8 days, there is persisting right upper zone opacity that is also extending to the right middle zone and abutting the right cardiac shadow on the right side as well. The child was started on ATT on 17th of May following these x-rays, and an ultrasound was also done outside, which was suggestive of doubtful hypoechoic lesions in the spleen, but the liver had no hypoechoic lesions or any suggestion of any focal lesion. When he came to us in July 2025, the right upper zone opacity along with right middle zone still persisted. However, there was a thymic shadow as well. Silhouetting was not very apparent on this X-ray. Outside CT scan had been also done prior to coming to us. This was from the month of May 2025, in which a well demarcated right upper zone opacity can be visualized, and on the axial section as well, right upper zone opacity can be seen. And the areas of breakdown and across, however, or any cavity cannot be well appreciated in this previous CT scan than outside because of some motion artifacts. The CT scan done in our center showed a right upper zone opacity with slight internal breakdown, but there was no apparent or any overt cavity noted. The rest of the lung appeared to be okay. However, some nodules were there, and right paratracheal and pretracheal necrotizing lymphadenopathy was also noted in the CT scan. It was reported as an active lesion in the right upper lobe with necrotizing lymphadenopathy, and right pre and paratracheal necrotizing lymph nodes were present. There was right upper lobe consolidation, areas of necrosis with some nodules as well. Because congenital TB usually enters from the liver per se, and the child had massive hepatosplenomegaly, ultrasound were done, but ultrasound has no obvious granuloma or focal lesions seen in liver. However, multiple hypoechoic areas which were not very well appreciated on the CT scan could be appreciated more on the ultrasound and suggestive, which raised the possibility that the child might have had a perinatal, the child might have acquired the infection perinatally. The investigations revealed anemia. However, the renal and liver functions were normal, with albumin of 2.7, which is slight, with albumin of 3.6, age ratio 1.4. Urea creatinine were 12 and 0.1. Total bilirubin, even after 2 months of treatment, was 1.15 with no increase in trans OT. The child was also suspected initially to have a storage disorder. So, on the basis of hepatosplenomegaly and poor growth, so a bone marrow examination also was done, which was suggestive of adequate linear hematopoiesis and no features suggestive of storage disorder. So, initial possibilities kept was tuberculosis, maybe a torch infection or a storage disorder. Points in favor of tuberculosis were the poor weight gain, localized chest sign, but there was doubtful or no contact history for tuberculosis as well as the mother. The antenatal history was not very clear, but other members of the family did not have tuberculosis. For storage disorder, the child had hepatosplenomegaly, but no family history or any history of sibling death. And for torch, the child had hepatosplenomegaly, microcephaly, but history of maternal fever could not be elicited. The tuberculosis workup, when it came to us in the gastric aspirate sample, Mycobacterium tuberculosis was detected. However, rifampicin resistance was indeterminate. So I just wanted to ask the audience that what will be the next step in this scenario? That you have a report of MTB detected, but rifampicin resistance is indeterminate.
Anybody in the audience would like to answer? Yeah.
We will repeat the sample, madam. Again, we will
Very
repeat the sample.
Exactly.
That is what we did. We repeated the sample, and the repeat sample came out to be sensitive, and a concomitant culture was also sent in the month, which came negative further on follow-up. So the child was continued treatment for drug-sensitive tuberculosis first. Now, coming to a short discussion, and after that, the follow-up of the case. Any other questions regarding the case and management initially? The child has been on follow-up, and those details will be shared later. But any other doubts regarding this the management done per se on the first visit?
Ask you, could you gather details about the treatment which the child had received outside? Because child was already taking ATT for 2 months when he had come to you.
Yes, ma'am. We checked it via the NICSHA ID as well and the records of the patient. So he had been started on intensive phase as per protocol, ma'am, and he came towards the end of intensive phase in the month of July to us, and he had been compliant to it.
Okay, so are you going to discuss it later, as you mentioned?
Yes, ma'am. The follow-up also we will discuss what happened.
Fine.
Any questions from the house? Question पूछा किसी ने? My question to you is, when there is no history of tuberculosis in the mother, how come you made the diagnosis of congenital TB?
Yes, ma'am. That's with the diagnosis of congenital TB as of now was not sure. We did not manage him per se. The diagnosis of congenital TB, the points in favor were that child had hepatosplenomegaly. The focus of infection probably would have been via the parental tract, but we are not very sure because as per the criteria for congenital TB, we need to exclude other causes of acquired tuberculosis, which was not very sure in this child. But in view of the doubtful maternal history as well, and he presented to us at the age of only 2 months, so we don't know what the history was before that, whether he was the follow-up of the child was also not that good after birth, and prior to birth also the mother had not taken any antenatal checkup. The parents had denied that there was no history of any tuberculosis in the family, but as per the criteria per se, the child was not exactly fitting in the congenital TB. So we had a doubt whether it was a congenital TB or early TB which he had acquired in the early stages of his life.
Also the management remains the same, but to label as congenital TB, I would say the history of TB in the mother or history of ATT.
Yes.
Even you said the mother was admitted in the hospital when she suddenly collapsed, and
Yes,
she
ma'am.
died probably on the second day. I'm sure the chest X-ray must have been done on her because she was in the hospital.
We don't have those records, ma'am. We had inquired. It was a very short visit, and according to the parents, she came into the emergency and expired within 1 hour. So that is why we did not label him per se as a case of congenital TB exactly, ma'am. But for discussion, we have taken.
No, I totally agree with you because we won't label it as congenital TB, but the discussion should, this is one area where we have not discussed till now. So we'll have a discussion of congenital TB because the house, I think, needs to know what are the criteria of how to label as congenital TB and from where the infection comes and what could be the presentations. I'm sure you'll be dealing with that. So over to you, I think, here.
Yes, a short discussion on congenital TB. Congenital TB is defined as tuberculosis infection acquired in utero or during delivery from a mother with active tuberculosis. It is diagnosed when TB lesions develop within the first few weeks of life and other sources of postnatal infection are excluded. This is an important point that the TB should come within the first few weeks of life, usually in the neonatal period or in the early neonatal period, and other sources of postnatal infection should be excluded, which was not very sure in our case. Congenital TB can have various modes of transmission. The first is transplacental or hematogenous spread, in which the mycobacterium crosses the placenta and infects the liver. That's why rather than the lung, which is the usual mode of entry for the tubercular bacillus in adults and children, the liver is the first site of entry in this subtype of TB. Aspiration or ingestion of infected amniotic fluid that causes entry via the lung or the GI tract, or rarely it can be acquired via the infected birth canal at the time of delivery. These are the three main modes of transmission: transplacental, aspiration or ingestion of infected material, or via the infected birth canal. In 1994, Cantwell et al. Had given the criteria which is still used to diagnose or label a case as congenital tuberculosis. It requires the mandatory criteria of tubercular lesions in infant, which was present in our case, plus one of either lesions in first week of life or primary hepatic complex or caseating hepatic granulomas, maternal, genital, or placental tuberculosis, and exclusion of other postnatal transmission. So as you can see, the first criteria was fulfilled in our case. Tuberculosis lesions were present in the infant, but the even 1 out of the 4 were not completely fitting in our case. The child is presented to us on 2 months. The liver per se was free. We don't know the history of maternal, genital, placental TB, and we could not completely exclude that the child did not acquire it postnatally. However, the Cantwell criteria still remains the mainstay for diagnosing congenital TB even in this day and age. The presentation is between 2nd to 8th week of life. The child will have non-specific symptoms, fever, poor feeding, irritability, failure to thrive. And as mentioned earlier, hepatosplenomegaly differentiates this form of tuberculosis from other more common forms in which the lung or respiratory are the first system. Respiratory is the first system to get involved. So respiratory distress or pneumonia, lymphadenopathy, fever, poor feeding, and irritability can also mimic meningitis, and it can present like a sepsis-like picture. And very rarely, this kind of TB can also present as skin or bony lesions. So in the investigations, maternal evaluation for active TB is the first line. You have to evaluate whether mother was having active TB or not. And for the infant per se, a chest X-ray, abdominal USG, gastric aspirate or BAL or CSF for AFP gene expert in culture, liver biopsy, or if you could have the placental histopathology to prove maternal tuberculosis can be done, and a tuberculin skin test is usually negative in this kind of cases as the response has not occurred yet. The treatment, however, is not much different. The child, when he came to us, he was on HRZD for 2 months, and as he had drug-sensitive TB, we had continued same treatment. If it is meningitis or miliary TB, we could have added corticosteroids. And the more important part is to treat the mother simultaneously, and breastfeeding is allowed with maternal treatment, usually if it is not drug-resistant tuberculosis. So in our case, as I had asked earlier, if case of CBNAT, MTB detected and RIF is indeterminate, next step should be repeat sampling. This is a short slide. If on the same, if MTB is detected, rifampicin resistance is not detected, treat as DSTB. If it is detected, treat as DRTB. But if it is rifampicin resistant indeterminate, then you have to retest and make sure whether it is DSTB or DRTB. On follow-up, the child came 3 days back to our OPD. He has had serial weight gain. As of now, the weight is 6.3 kg. He is on continuation phase. The hepatosplenomegaly has improved. The abdominal distension also has decreased. And he is developmentally appropriate as per age. He is a 6-month child. He is having neck holding. And he has attained all other milestones as per age. Any queries with the case?
I wanted to ask you, you were saying that the child was taking ATT before. His compliance was good. So what was the reason that you evaluated for the child not gaining weight that he was referred to you?
Initially, we had asked regarding the compliance per se, ma'am, and checked the compliance. The parents were quite compliant to the treatment. Then, in view of whether we thought that they might, because they did not have a microbiological diagnosis. So we had suspected it could have been DRTB as well, because the poor weight gain was there. However, he was taking treatment per se. So when he came to us, we evaluated him as a fresh case. We isolated the organism. Initially, the indeterminate report came, so we suspected that it might have been DRTB. But we immediately retested it, and a concomitant culture had also been sent, which came out to be negative. So he was found out to be DSTB only per se. We improved the nutrition of the child. We gave nutrition advice as inappropriately fed with proper dilution as the grandmother was taking care of the child. So we took the factors into account, did nutrition counseling, and we attached to them to their local PHC and took regular tele follow-ups of the child as well. And they have come in the last 2 months, every 15 days they have come to the local site, and 2 months taking follow-up. So serial weight gain has been demonstrated, has been compliant. Continuation phase will end this month.
What about the household contacts? Any screening of the caretaker, the contacts in the household?
Yes,
Have
ma'am.
you done that?
Yes, ma'am. When they had come to us, the father and the paternal grandmother were there. We had done chest X-rays and screening of both them, but they did not have any active signs of tuberculosis. The chest X-ray was normal as well.
The
For
rest
the
of the
mother,
family? The rest of the family?
Rest of the family also, the rest family could not come here, ma'am. But we had inquired that any history of any history of recent long-term cough, long-term fever.
So,
We
doctor,
even
that
asked.
is that this is mandatory under the program. The household
Yes,
contacts need to be screened.
yes,
If this is being done, kindly ensure this is not done in the future. You have to just counsel them to bring all the family members.
yes,
Yeah, in fact, still the child is under, the baby is still under treatment. So,
yes,
as Dr. Urvashi, she has pointed out, it's very pertinent, to get all the members screened. Because if the source remains, the child may develop TB again. And the range for them, I know it's very tough in Uttarakhand to get, people to come, but this is very, very important, to have a household detailed screening with chest X-ray as well as the sputum sample.
yes, ma'am.
Then
The
you have a
immediate.
Can I say something on this?
yes, please, ma'am.
As you said, it is difficult, and we have a very good active program, NTP program in the state of Uttarakhand. And we always communicate this to the center where the patient is going to go back. For example, this patient is from Rudraprayag, which is a little away from, and not just from Rudraprayag, actually from a village which was there. And transporting the whole family from there is not possible. So we inform the state.
Yes,
And
ma'am,
it's
that
actually,
is,
as you
we
know, the
acknowledge that, yeah, what you're saying is very, very important. It is the public health action is for the DTO. It is for the DTO to do. I was just wondering if somebody ensured a direct connect with the DTO and instead of the family, we must inform the program
no,
officer
we
that
always
this
do that. We have a very
DT.
active,
So I was only wondering if your team knew if it was done and if they were aware. So
oh,
when you
yes,
were labeling it as congenital TB, if you were aware, what was the other possible contact that the patient could
Yes,
have
ma'am.
got TB from? Then
Yes,
you could have been peaceful about it is not congenital, but a child got TB from, I mean, it was a pediatric
and
TB.
it doesn't really matter whether
It
this is
doesn't matter, but
congenital
since
or
they,
anything else. We have seen cases of congenital TB earlier. But in this patient, it could not be established because the mother is not there. For establishment of diagnosis of congenital TB, you need to demonstrate TB in the mother. The one who has passed away, and we don't really know what the cause of death was because she suddenly passed away. That's not the way patients of tuberculosis die. It could be thromboembolism or something like the way she passed away within an hour of coming to the hospital. And so the diagnosis, whether this is congenitally acquired, perinatally acquired, or acquired postnatally, is not clear. But definitely there was, gene expert was positive from the respiratory samples. So that is where the case is. But since there were some lesions, I think, in the liver as well, which could somewhat indirectly suggest that there was this could have been acquired transplacentally. That's the only evidence. Otherwise, this is just a case of a child with TB as an infant who has lost his mother, care being taken by the grandmother, not very adequate. So we were not very sure about the way drugs are being administered and the way nutrition is being affected. So all these things were definitely there, but we have to manage patients in coordination with the state. And most of these patients, will be getting their drugs from the state. And their subsequent follow-up also is done at the at the NTP center, wherever they are attached in the community hospital or in the district hospital. So
so
that
I
is
would
where it
then
is.
like
And
to know,
DTO is
madam,
always
I would
contacted.
like to know what was the experience from the program. Did you get adequate support?
Dr. Khushbu, I think you can tell about this. I think there was a connection because we have regular meetings with the state TB officers and we discuss all our cases and they also discuss about the problem. But definitely there are certain problems of reaching patients. And that is why we have been using some innovative methods of transporting samples, etc. But in this patient, what exactly has, how big is the family? And it is not just the family, it is also the surrounding people who are around. Sometimes the contacts would escape detection because sometimes it is the maternal side or the paternal side. You don't really know what's happening because tracing contacts in TB is not a very easy job. And sometimes, if the community is having that disease, you may not actually find a contact, but you will still label that contact is positive. So that is what the
Yes.
situation is in some of these districts.
Good afternoon, ma'am. As ma'am had just pointed out, there were 4 other family members who needed being contacted. So, through DOTS channel as well as through personal communication via AIMS Rishikesh, we had contacted the nearest PHC first and then the DOTS Plus center where they're getting treatment from. There are certain lacunae, ma'am, in the support that we get sometimes. Although in this patient, they had told that there were 4 other members who could not travel from that far off and they were being called to the center. Further, in the Nikshay, it's not updated, so we will check again, which is the plan for follow up of this child. And the child will be again coming next month, so we've still asked them. And as ma'am had addressed, in cases like this where we feel it is too far and it is not something that we're able to get satisfactory response from, we're trying to get a project done where we through drones we are trying to transport a sample of the patients here, so that if the family cannot come, then at least the sputum samples can be done for adults. And if their x-rays have a doubt, then they can, through the channels, come to our center for testing if there is some problem that they are facing. So since these are the 2 avenues that have been established at our institute, the child was first being addressed to the first state normal channel. And since we're facing some issue here, we are trying to get the samples via drones also this time.
Okay.
Any other questions from the audience? I think there is a confusion about the treatment that was given. The treatment that was given was for DSTB only.
So, Sangeeta
in
ma'am,
the slide-
I have a query.
Yes,
Sangeeta
sir.
ma'am, I have a query.
Yes, sir.
So as told by DDG ma'am, Dr. Urvashi Singh, the contact tracing should have been initiated in the Srinagar Medical College, because the place where the patient first contacted, it should have been there, and it is very important for the program, important
Yeah,
component of
very
the program. Yeah.
exactly. Extremely important, I would say, when you have a congenital. That means it's in the community. The adjacent community will be a caregiver because the mother died without we knowing whether she had TB or not. So contact tracing, no doubt, is very important in this child.
And the Rishikesh is far off from that place, so best should have been the Srinagar Medical College.
Mhm. Totally
Thank
agree. Totally agree.
Thank you. Thank you.
Mhm. There was another question, I think, about whether M. bovis. I read it on the screen. Is there a question?
Regarding the primary vaccination, what is the status of the child regarding the primary vaccination actually, the BCG and other vaccine?
The birth dose was given. Birth dose had been given, and when the child came to us at that time, the vaccination was appropriate as per it.
BCG was given?
Yes, the BCG had been given at birth. That was document was there. Those cards they had. That card was there because it was taken immediately after birth to the nearby healthcare center. That thing they had.
And they did not know that the child has TB, so they gave BCG.
Yes,
I think that must have been the scenario, yeah.
Those symptoms came later on, around 1.5 2 months.
Yeah, because if it is diagnosed at birth, the important is to start treatment immediately, and then you can postpone the BCG when the treatment ATT is completed. But in this case, probably there was no suspicion that the child has congenital TB or TB at birth, so they gave BCG, which in this scenario stands valid. Any other question?
So there is a question with regard to the possibility of Mycobacterium bovis infection by BCG vaccination at birth, and can CBNAT rule it out, or is there any need of AFB culture?
Would the team like to answer this question?
I can address this if.
Yeah.
Yes, ma'am.
So, gene expert will pick BCG as well, so it will not differentiate.
Yeah.
The bottom line is it would be good to do it, but it just needs another, PCR specifically designed for bovis. So when there is a suspicion, it can be done because the treatment will be different. You'll have to drop PZA and add a quinolone. So when suspected, we can look for it. And not everybody has that PCR available. So yeah, it has to be done using a further test. Gene expert will detect it as TB because it's TB complex anyway.
Causing this lung infection in the right upper lobe is not would not be the clinical scenario. If it is due to BCG, there could be a local, infection or in the axillary lymph node or disseminated TB. But just to have a right upper lobe involvement, BCG, it is not due to BCG. So that is one thing which can be differentiated.
There is one question regarding the history. Is there any history in other family member?
वो तो हो गया
नहीं
नहीं
है ना?
वो तो that is there.
That is it.
Any other question anybody wants to ask?
So there is another query with regard to hospital staff. If the hospital staff can transmit infection in any way, contact with the baby, and can we screen them for source of infection? So would the presenting team would like to answer this question? If the hospital personnel were responsible for transmission of infection.
In this case, the hospital stay was quite short. It was just a 1 hour stay, just for the well-being of the child. Initial workup was done, and he was vaccinated and sent back home, as the child was healthy apparently. So I don't think that might have been transmission.
I would like the previous question regarding CBNAT. As Dr. Urvashi has said, CBNAT will not differentiate between MTB and M bovis. But if it is, CBNAT smear positive, then you can also go ahead with LPA. LPA with the tub band would be able to differentiate MTB from M bovis. Or next is, as written in the question, you go ahead with the culture or specific tests which are meant for M bovis, as Dr. Urvashi has highlighted. So these are the tests which are available to differentiate, M bovis and MTB.
So I hope this clarifies the confusion between M bovis and MTB. Any other questions from the audience?
So I think the question that was raised, that following the BCG injection, if the child got the TB, BCGosis, probably Dr. Sangeeta, you can talk a little more about BCGosis.
Yes, please.
Yeah, so you said alone, right, upper quadrant will not be the presentation. Kindly talk a little more about it for everybody's benefit.
As we are aware, BCG is given under the national program, immunization program to all. It will be within 1 month of birth. But as and when the child comes, if it is missed at birth, as and when the child comes. Now, the data which is there for BCG is not a perfect vaccine. It has some protective role for primary infection. The newer meta-analysis has shown that it does benefit for the primary infection, but it will not prevent it in toto. So, but what is certain is that BCG does prevent the dangerous forms of disease as well as dissemination. So that is the reason we always prefer giving BCG even to patients who are, mothers have TB. So if there is a child who is born to a mother who has TB during the pregnancy, The first step is that we need to differentiate when the child is born whether the child has TB or not. Uh, Starting with clinical examination, a child who's born with congenital TB will obviously be IUGR and have microcephaly, as was in this case, was not growing well, anemia at birth, and then you get some investigations done, a chest X-ray and an abdominal ultrasound. Abdominal ultrasound for liver primary focus, which if the infection is through the umbilical vein, the focus will be formed in the liver, and then it has an hematological
Sunita, can I
spread.
just come in? I just wanted to make
Yeah,
two statements. I'm actually going for a meeting. I'll not be able to
yeah,
continue
yeah.
after that.
Yes,
So,
yes,
small things I wanted to convey. One is that
yeah.
basidiosis will only happen if the child is immune compromised,
It's immune
and it will be
compromised.
a disseminated infection. It could, in fact, present as skin ulcers or involve several organs.
Yeah, yeah,
The
yeah.
second thing, when you said LPA, there'll be an M-bovis band. There is no M-bovis band in the
No,
LPA.
no, MTB band, ma'am. Not band.
So MTB complex is picked up by both. It
Yeah,
doesn't differentiate. Neither LPA nor gene expert will differentiate MTB from M. bovis, because
okay.
both, along with 7 other species or 8 other, newly defined subspecies, keep getting reported. It's an MTB complex which includes 9 to 10 subspecies, which are so LPA and gene expert will both give MTB complex positive. So just to add to what previous discussion was,
Bovis,
if we want to actually know, in case of suspicion of bovis, there can be an additional PCR which can be done to guide us whether it is M. bovis or MTB. Thank you so much.
okay, okay. Thank you so much. That's very informative even for me, because I had the impression that LPA has the tub band, so it differentiates between M. bovis and MTB. But then, as you said, that the complex, as there are other organisms like Kp, etc., and the complex, they will also not be differentiated. They'll be positive by the tub band. So now, carrying our discussion forward, so if the infection is, as has been highlighted, the most common method is infected placenta through the umbilical vein. The infection reaches the liver and it causes the formation of a primary complex in the liver. So that is the reason we get an ultrasound done at birth. And further, it will cause dissemination, hematological dissemination, leading on to biliary tuberculosis. That is the commonest scenario in case of congenital TB. Now, if the infection occurs due to any disruption of TB focus, which is on the surface of placenta, that causes infected amniotic fluid which the child may swallow. In this case, the lesions will develop in the lung, similar to what you have in this case, the one which has been shown. So that will have a primary focus in the lung, followed by, depending upon the immunity of the child, it can cause the lesions as was highlighted in this case. And the third is during the labor, as the passes through the birth canal may again ingest infected secretions, and again the lesion will be either in the lung or in the GIT. So that is the reason, to rule out congenital TB, we always get a chest X-ray done, an ultrasound abdomen done, and also gastric aspirate done. And all the contacts of the child, they need to be screened for the source. Now, coming to the treatment, depending upon whether it is TB infection, we no longer call it as latent TB infection. It is either TB infection or it is TB disease. If it is TB infection, then the next step is that we need to continue breastfeeding in both the cases, be it TB infection or TB disease. Continue face mask. Next is, if it is TB infection, we start chemoprophylaxis with INH, 6 months of INH. given in the dose of 10 milligram per kilogram body weight, and dose adjusted as the child gains weight. And the last thing is we need to even give BCG, as we have discussed that BCG does definitely have a role in prevention of dissemination and dangerous forms of the disease. Although there is limited role in prevention of primary infection. So if it is disease, we give the ATT depending upon whether it is drug sensitive or drug resistant. And as has been given in this case, so I would like to ask the host team regarding the duration of ATT. Till how long do you plan to give ATT in this child?
6 months total.
Okay. I would say that you need to do an assessment at 6 months because the child has lesions in the spleen also.
Yes.
So with lung and spleen, it is a disseminated disease.
Yes.
So in this case, the program allows extension up to 1 year. So total treatment duration can be 1 year, 12 months.
Yes.
With the assessment done at 6 months and then again at another 3 months. So extending every 3 months to the total duration of 12 months. So 12 months ATT is given for which all conditions?
Skeletal tuberculosis,
Very good.
meningitis also has long duration.
Very good. Very good. And disseminated TB. So what is disseminated TB?
One of involvement.
Yes.
Usually, or miliary with hypoxia.
Very good. Very good. Miliary or more than one organ involvement with a one uninvolved organ in between.
Yes.
So non-contagious organ in between. So that is disseminated. So you're doing a perfect job in this child. So the saturation is normal in this the socks.
I could not get the question.
No, you said that the saturation was 96% on room air at the time of the child was brought to the hospital. I'm asking about the saturation status now. The child is maintaining oxygen saturation.
Yes, ma'am. The child was maintaining. With abdominal distension per se, some splinting of the diaphragm was there, causing some respiratory distress initially. But on the follow-up, we have noticed that it has much improved significantly.
So you are continuing with ATT. That's it, or anything else also?
No, ma'am. ATT and nutritional advice per se, and regular vitamin supplementation as per the protocol.
Should steroids have been given? Yes or no?
There was no hypoxemia, ma'am.
Yeah.
Hypoxemia
That is very important, the indication of steroids. Because the child was 96% is a good, reasonably good saturation. There was no indication of steroids, and there was no miliary TB with, AV block, and there were no other indications of steroids like TBM or pericarditis. So there is no indication of giving steroids in such a case, be it congenital, be it postnatally acquired. The treatment remains the same as what you are doing.
Yes.
Dr. Kamal, you would like to ask something? You unmute yourself. Unmute yourself.
Yes, ma'am. So I think you have asked very pertinent questions regarding about the duration of therapy, about usage of steroids. These are very pertinent questions. I think the host team is doing good.
Any other questions?
Any other questions from the audience? In the meantime, you can also attempt the post-test questionnaire, the link for which has already been shared in the chat box. Any more questions from the audience? Okay, if there are no more, questions from the audience, then we would come to the end of this session. Today, we had a very fruitful discussion, and I would like to thank Team AIMS Rishikesh for bringing forth this important topic on congenital TB. The discussion brought forth important points with respect to contact screening of the family and also differentiation of MTP complex using Gene Expert and LPA. The case also highlighted the importance of nutritional rehabilitation in patients. Like in this patient, the team also achieved microbiological confirmation in the patient, which was lacking. And second, they found the cause for non-response, and that was poor nutrition. Once that was taken care of, the child started improving. So many a times, these small things are often overlooked, and we start to look for more rare things. So we should always focus on simpler things, and we should always encourage nutritional rehabilitation of patients, also ensuring the compliance of medications. So thank you, AIMS Rishikesh, for this important case discussion. Before we wrap up, I would now like to invite Dr. Ashok Bhardwaj, Chairman, National Task Force, for his closing remarks. Over to you, sir.
Thank you, ma'am. Thank you, Sangeeta, ma'am. So it was a wonderful case. So I must compliment the team, AIMS Rishikesh. So here I also want to say that the AIM Rishikesh, the program activity are best among all 23 AIMS in the country. As Dr. Minu also told, they are actively involved in NTP activity and regular meeting with the state TV officer. So what more I want to say that the patient, once it comes, so family contact has to be traced, and the relevant, whether TB diagnosed or infection, should be managed accordingly. So thank you, madam. Thank you for giving me a chance. Thank you very much.
I request the audience to please attempt the post-test questionnaire, the link for which has been shared in the chat box. With this, we come to the end of the 18th Pediatric TB Eco Clinic. The next TB Eco Clinic is scheduled for 16th of December. So we will meet again on 16th of December for the next discussion on pediatric TB.
I would also like to invite all delegates because I want to give you also a chance to come up and be in the forefront rather than being silent spectators and listening and learning. I want you to be speaking and learning and make us learn. So please do, send us requests. If anybody wants to present, we already have a pipeline which is there with the institutes who have already signed in that they'll be there. But we'll be more than happy to involve you and we look forward for that cooperation. So with these words, Dhulika, I think it's a call of the day.
Yes.
And thank you, Dr. Meenu Singh, for being there and being your program is doing the best for the country, I would say. Uttarakhand is always at the top. And with your drone program, how you transport the samples as well as the drugs, I've seen myself during my visit to Rishikesh. So thanks the team to come forward at such a short notice when we were struggling in to find a replacement. So thank you all for joining in.
Yes, thank you, everyone. I hope you have attended the post-test questionnaire. The session will remain online so that you can get ample of time to attempt the questions. See you again on 16th of December for the next TB Eco Clinic.